Hi, my name is Mariah, and I will be doing my capstone presentation on a bilateral mastectomy. The patient was a 49-year-old female with a diagnosis of a left node positive grade 3 invasive ductal adenocarcinoma that was estrogen 98% positive, progesterone 99% positive, and HER2 negative. She underwent 4 cycles of AC chemotherapy followed by Taxol. She had 36 genes tested and none of them showed a mutation. The surgical plan was for a bilateral skin-sparing mastectomy. She did not want a nipple-sparing mastectomy. And then she was also going to get reconstruction with expanders placed. The surgery also included a biopsy of the left sentinel node and excision of the left axillary node. 4 lymph nodes were marked via a Savvy Scout and sent for biopsies during the surgery. The patient will start radiation treatment 3 to 4 months post-op, and spacers will be replaced with implants in about 6 months after the radiation treatment has ended. Her past medical history includes atypical squamous cell of undetermined significance with a high risk for HPV cervical cancer, COVID-19 infection, chickenpox, a vascular surgery, which was an endovenous ablation, a breast biopsy, a colonoscopy, and a Mirena IUD placement. She has a family history of breast cancer with her mother and her maternal aunt, and hyperlipidemia with both her mother and her father. With the nursing assessment, her physical assessment, she had a temperature of 97.3 degrees Fahrenheit, a heart rate of 73, respiration of 18, O2 saturation of 98% on room air, a blood pressure of 122/73, and a pain of 3 on a 0 to 10 scale. She described it as aching. She was A&O times 3. She had non-labored and regular breath patterns. She had clear bilateral breath sounds throughout, and no cough or sputum was present. For cardiovascular, her S1 and S2 were regular. She had bilateral radial palpations of 2+, and less than 3-second cap refill. Skin was warm, dry, and normal for race. For her gastrointestinal, she had no GI symptoms, she had active bowel sounds, no complaints of nausea or diarrhea, and the patient did mention that she has severe motion sickness. She had no present edema. For the diagnostics that were done before her surgery, she had a left lymphoangiogram, the Savvy clip placement, which was the 3 nodes total, and 2 chips for location during the surgery. For her medications, she was given Apriant 40 milligrams. This was pre-op to help prevent nausea, a scopolamine patch, which is also pre-op that will prevent nausea. She had Tiva, which in the OR, which is propofol, and this just means that they don't use gas in order to help with her severe motion sickness. Dexamethasone, which was given in the OR to prevent nausea. Droperidol in the OR to prevent nausea. Ketamine in the OR to prevent nausea, and aldosterone Zofran IV push for the PACU, and also post-op in order to help with any nausea that she may have, specifically because of her severe motion sickness. For her lab values, she had a glucose of 105, a sodium of 142, potassium of 4.1, and a BUN of 8. Looking at her CBC, her white blood cell count was 3.5, which is low. A normal white blood cell count is between 5 and 10. Her RBCs, her red blood cells, were also low at 3.03, and it's supposed to be between 4.2 and 5.4. Her hemoglobin was low at 10.3, and a normal range is 12 to 16. Her hematocrit percentage was also low at 29.9%, and a normal range is between 36 and 48%. Her autoeosinophil percentage was high at 8.2, where a normal range is between 0 and 6%. And then her lymphocyte number was also low at 0.68, when a normal range is between 1 and 4.8. With her CBCs, with a lot of those being low, she was diagnosed with chemotherapy-induced neutropenia, but she was still given the go-ahead to go through with her bilateral mastectomy. For the nursing diagnoses, I have nausea related to anesthesia as evidenced by the patient stating they have severe motion sickness, risk for surgical site infection related to bilateral mastectomy and reconstruction, the spacer placement, and then risk for powerlessness related to cancer diagnosis. For the planning, in order to help with the nausea and to help reduce that, especially because of the severe motion sickness, she was given the scopolamine patch, which just goes behind the ear and can be worn for 3 days preoperatively. And then she was also given the aprepitant, which also helps with nausea pre-op. And then she was given all of those medications in the OR during the surgery and before she woke up in order to kind of help prevent any nausea. And then she also had Zofran on her MAR for while she was in the PACU and PRN doses for post-op. The patient was frequently asked about her nausea, and the nurse ensured that her nausea was under control before she went home and was discharged. The patient was also educated to eat any food before taking pain medications to help with upset stomach. The patient will eat something before taking any pain medications while in post-op, and the patient will report having no nausea before discharge. For the surgical site infection, the PACU nurse looked at the surgical wounds and surgical dressings with the surgical team during handoff, and then the PACU nurse also looked at the surgical wounds and dressings with the post-op nurse during their handoff report as well. The post-op nurse educated the patient on signs and symptoms of an infection and also educated the patient on care instructions for the JP drains that she had placed during the surgery. For that, the patient will verbalize understanding signs to watch for with her surgical sites and be able to retell the nurse the signs to watch for before discharge. The patient will also be able to verbalize understanding and perform teach-back for the care of her JP drains before discharge. The nurse would listen to the patient and any concerns that she voiced during her time in pre-op, PACU, and post-op, especially with this risk for powerlessness due to her cancer diagnosis. The nurse will watch out for signs of distress or the patient having any overwhelming feelings. The nurse will let the patient know of any support groups and other services that are available for her and her family members. And then the nurse will provide the patient with information about services if requested before discharge. Patient will discuss any questions or concerns with the nurse before time of discharge, and patient will state understanding to direct any further questions or concerns following discharge to the provider's office, which the phone number is provided in the discharge instructions. The picture that I have up in the corner there is just the different types of mastectomies that can be performed. So the patient had the one in the middle, which is the skin-sparing mastectomy, where they completely cut out the nipple. The one on the right-hand side is the nipple-sparing, where they will save the nipple during the surgery. And the other one on the left is just a traditional mastectomy, which I did not get to observe. For implementation, the patient received numerous medications in the pre-op, PACU, and post-op settings in order to prevent and control her nausea. The patient was also frequently asked about if she was feeling nauseous at any given time, and she was also given food before she received any pain medications in post-op. The nurse also discussed the patient's surgical sites with the patient and a present family member, hygiene, wound dressing care, JP drain care, any movement and weight restrictions, and then also signs of infection were reviewed with the patient and family member. The patient and family member both stated understanding, and all of their questions were answered prior to discharge. The patient was instructed to contact their provider's office with any further questions or concerns. The nurse was there for the patient throughout each stage of the surgery and listened to the patient if they had any questions or concerns or needed any emotional support. The patient was also made aware of available resources and advised to contact their provider with any other concerns or questions or resources that could be available to her. The patient stated understanding before discharge. And then for evaluation, as far as I was aware, the outcomes and the interventions were effective. The patient was able to state understanding, and all of their questions were answered at the time before discharge. And like I said earlier, the phone number for her provider's office was given in the discharge information. The patient was able to verbalize that they didn't have any nausea or pain before discharge and that everything was under control, and that she knew to eat something before she took any pain medications, even ibuprofen. And then the patient did not state any feelings of powerlessness prior to discharge, but was made aware of the services that is provided to her. Thank you.